Okay, so we should probably give just 1 or 2 more minutes for everyone, for more people to join. If not, we'll just get started in 2 minutes. So we're going to start in just a minute or so. If anyone has any questions that they'd like to post, feel free to post them on the chat or in any form that you are watching us on. So I know some are Facebook Live and some are on some other devices. So just put your any questions that you're having. We're monitoring all forms of questions. And we'll begin now. So good evening, everyone. My name is Dr. Carolyn McCummings, and I am the Director of the Nassau County Office of Health Equity. The mission of the office is to improve the health and well-being of residents living in underserved and vulnerable communities throughout Nassau by collaborating with community partners and health partners to provide initiatives that help ensure greater health outcomes for those living in these communities. This evening, we are collaborating with the Cancer Services Program of Nassau County and the Adelphi Breast Cancer Program to present this virtual event, Returning to Cancer Screening. We know that many people may not have had their regular cancer screening since before the pandemic changed our lives and our regular routines. We also know that the number of cancer screenings happening nationwide have plunged when the lockdowns went into effect, meaning many of the people who would be seeking care don't yet know that they have cancer at all. For this reason, it is important that folks begin to fall back into their medical screening and cancer screening routines now. Let me now introduce our presenters. First, we have Sarah Parise, and she is the Director of the Cancer Services Program of Nassau County. She is a certified oncology nurse and oversees and coordinates the CSP to increase access to much needed cancer screening services for uninsured residents, regardless of their immigration status. The goal of the CSP is to diagnose cancer at its earliest and most treatable stage. Also joining us today is Alejandra Hernandez. She also is part of the Cancer Services Program, and she is an outreach educator. We also have Angelica Medina, and she works at the Adelphi Breast Cancer Program. She is the outreach program supervisor for their initiative, Sisters United in Health. Angelica plans initiatives and programs to provide underserved women of color throughout Long Island with free bilingual breast health education and connect them to the resources they need. So let's begin our program with Sarah.
Thank you, Dr. McCummings, for having us, for collaborating this evening. We're really excited to be able to get the word out about continuing cancer screening for all. The first thing that we are going to talk about is facts about cancer. Cancer is the second leading cause of death among New Yorkers. Cancer screening can save lives through different means. We can find cancers early at a more treatable stage, or we can find pre-cancer lesions that we can remove or diagnose before they turn into cancer. So we can, early detection can save lives. Screening with a mammogram can help find breast cancer, like I said, early when treatment is most effective. We'll talk about stages of cancer later on. However, the earlier the stage of any cancer, the easier it is to be treated. Cervical cancer and colon cancer, as we will also discuss today, may be prevented through regular screenings. There are many types of cancers with many possible causes. The three we are going to speak about today are breast, colon, and cervical cancer. However, there's tons and hundreds of other types. So if you have specific questions about a specific type of cancer that we're not discussing today, we are also going to give our contact information out at the end, and we're happy to share and answer any questions that you may have. Many things can affect a person's chance of getting cancer, called risk factors. Risk factors may include age, race, family history. Some individuals with many members of their family with a certain type of cancer are at higher risk to also develop that type of cancer. People that are older, so the older we get, the more likely it is that we could develop a cancer. And some races are at higher risk for developing certain types of cancer as well. People can still get cancer even if they do not have any risk factors. So this also brings the point of screening and early detection as a very important fact. Screening for cancer means checking for cancer before there are any symptoms or problems. Breast, cervical, and colorectal cancer are the three cancers that we screen for in the Cancer Services Program, and we say that regular screening can save lives. So I'm going to hand it over to my colleague, Angelica, who's going to be talking about breast cancer. Then I will talk about cervical cancer. Then our colleague, Alejandra, will talk about colon cancer, and then we will take some questions. So thank you again.
Good evening, everyone. I'm Angelica Medina, and I'm going to tell you more about breast cancer. So before we do that, let's discuss what cancer really means. And as we know, our bodies are made out of cells, and these have very organized patterns, but sometimes, unfortunately, there are genetic changes or changes to our DNA, and it basically makes our cells go rogue, and they will replicate without any type of organized pattern, and they don't die. So this typically results in tumor generations, and when this process happens in the breast area and the tumor is malignant, that's what we call breast cancer. So breast cancer can spread to other parts of the body, particularly if it's not detected or treated early. It can happen at any age, but it's usually diagnosed in women over the age of 50. So as we get older, our risk increases, and usually as you get into your late 40s and 50s, that you see that increase in risk, hence the importance of starting your screenings at that age. So breast cancer is a complicated disease, and there are many different factors involved. We don't exactly know why some people will develop breast cancer and others don't. But scientists and doctors do agree that there are some risk factors that make some people more vulnerable than others to develop breast cancer. So the first risk factor would be being a woman. So that alone is the main risk factor in breast cancer. And that has something to do with a hormone that we all have called estrogen. Not the bad guy, but it does play a role. And especially when you have excess estrogen exposure, it can increase your risk. Breast cancer really likes estrogen, or most types of breast cancer do. The other risk factor is getting older. So as I mentioned in my previous slide, most breast cancers are diagnosed in women over the age of 50, and the risk increases as we get older. Another risk factor is when you've had previous breast cancer or some non-cancerous form breast changes or benign breast changes can increase your risk as well. Also, having family members, especially first-degree family members, such as your mother, sister, father, let's not forget about the father's side of the family as well, or even male family members or daughter. If they've had breast cancer, especially when diagnosed at an early age, those are red flags that might increase your risk. And some people might have that family history, but might also have a genetic mutation. There are multiple genes involved in breast cancer development, but we know of two main ones known as the BRCA genes, BRCA1 and BRCA2. And people can get tested for this mutation, but not everyone needs to do that. That's when there are multiple red flags and you have above average risk. Other risk factors include having or giving birth to your first child after the age of 30 or never giving birth, and also women who never breastfeed. So breastfeeding has been shown to have a protective effect against breast cancer. So especially women who breastfed for over a year see a reduction in the breast cancer risk. And there are other hormonal factors that are associated with breast cancer, and that includes having women who have their first menstrual period when they're under 12 years old. Any woman who starts or goes through menopause later on, meaning 55 and over, or any long-term use of hormone replacement therapy, which decades ago was seen as a miracle treatment for the side effects of menopause. But unfortunately, many of those women ended up developing breast cancer later on. Another risk factor in breast cancer development that is not, I think more recently we have been talking about it more, is dense breast tissue. And dense breast tissue is not necessarily something we can perceive. It's not about the size of the breast or even how they feel, how your breasts feel. It's more about the type of tissue in the breast area. So women have two types of tissue or different types of tissue, including fatty tissue and also glandular tissue or fibrous tissue, which are those lobules that produce the milk and other parts of the breast. So women who have less fatty tissue have dense breasts. And the issue with this is that when it makes the signs of early cancer more difficult to be seen on a mammogram. So it makes early detection a little bit more difficult. So women who have dense breasts tend to have higher risk of breast cancer as well. So women who have dense breasts should really talk to their doctors, their healthcare providers about any other risk factors, because that way you can make an informed decision about what other screenings or what additional testing you'll need to enhance or any early detection. By law in the state of New York and many other states in the country, your mammography report has to say if you have dense breasts, because that way, again, you can make that informed decision. Most likely they'll do a sonogram in conjunction with the mammogram to increase your chances of detection. What is important to note is that all women are at risk, and sometimes this disease is very complicated. So sometimes women can have one or multiple risk factors and not get breast cancer, but some other women can have no risk factors and they have breast cancer, or they will develop breast cancer. So that is why screening is very significant for all women, regardless of the presence of risk factors. So when we talk about early detection or screening, we have 3 tools. First, get to know your body, make sure that you're aware of any changes that occur in your body, and talk to your healthcare provider about those. Don't dismiss any changes. And also be persistent if the healthcare provider is not necessarily paying attention or not listening to you, and you feel something, it's different, definitely persist. The second tool that we have is the clinical breast exam, and that is where the healthcare provider palpates, looking for any signs or any changes that might be suspicious. Why is this going so fast? Okay. And then last but not least, the mammogram is the gold standard of breast cancer early detection. It can detect breast cancer when it's even too small for us to notice. So it's a crucial tool in early detection of breast cancer. So, again, I think my PowerPoint has a mind of its own. So mammograms may find signs of cancer even before symptoms or problems appear. Mammograms can help find cancer as early as possible, when treatment will more likely to be more efficient. And getting mammograms regularly, again, is key to early detection. When should we get our mammograms? So different medical and organizations have different views, but most likely, or the consensus is that women at average risk should start getting their mammograms between 50 and every 2 years at age 50 and continue till age 74. But for some women, it makes more sense to do their screenings every year, starting at 40. And some women even choose to start do a baseline mammogram at 35, and then if everything is okay, they will continue at 40. So definitely talk to your healthcare provider about that, because all your risk factors need to be considered as well as you choose at the age at which you're going to start your screenings. So with that being said, I'm going to pass it back to Sarah, who's going to tell you about cervical cancer.
Angelica, you did an amazing job. Thank you so much. You know, there's so many things about breast cancer that not everybody knows. You were very clear in, you know, explaining what a mammogram is and, you know, why people should be screened. So thank you so much. We're a great team here to present this to all of you. Our next topic that we're going to speak about is cervical cancer. So women have cervixes, and when women go to their annual GYN appointment, this is what we get tested for. So we get something called a pap test. Cervical cancer starts with abnormal changes to the cells on the cervix. It grows extremely slowly over time. And cervical cancer can begin as an infection. So one of the things that we test for when we're looking at a Pap test is an HPV infection in the pathology or in the cytology of the sample that we're taking. So we look at that, and then we look to see if somebody has had this HPV infection, which is a common virus that's passed from one person to another during sexual intercourse. It can lead to cancer in the cervix, but it can lead to cancer in other parts of the body. And we do talk about the HPV vaccination for younger children, which is not necessarily something we're speaking about today, but some things that do come up and questions that do come up is that can we give the HPV vaccine to the younger kids that would decrease their risk of obtaining this infection, which then would decrease their risk in turn of developing cervical cancer? And yes, that would be true. So speak to your doctor about any HPV vaccine if you have some children of that age, usually 14 and younger, boys and girls. So nearly all cervical cancer is caused by the human papillomavirus or the HPV infection, as I stated. In addition to this, other factors can also increase the chances of getting cervical cancer. The age, just like Angelica was talking about with breast cancer, the older we get, the more likely it is that we can develop any other different types of cancers as well. Not having regular Pap tests. So by having Pap tests on a regular basis, we can find early cells that can be removed that can prevent cancer from happening, or we can detect if somebody has the HPV infection that we can also do treatment for that can decrease the risk of cancer later on. Also, too, not following up with a healthcare provider after a Pap test, that's not normal. It can turn into other things that we don't want it to turn into. So we always want to get follow-up when we have an abnormal Pap test. Smoking is also a huge risk factor for cervical cancer. Some more risk factors of cervical cancer. Having been treated before for cervical cancer or any abnormal cells that may become cancer. Like I stated before, if we have an abnormal Pap test, it's very important to get that followed up. Usually women that have had birth control pills for 5 years or longer are also at risk. Giving birth 3 or more times, because this can change the cellular makeup of the cervix and can lend to a higher transmission of the HPV virus. Again, having multiple sexual partners, having HIV, the virus that causes AIDS, or another condition that makes it hard for your body to fight off infections like the HPV infection. Having a mother who took DES, and I am not going to try that word, while pregnant with you can also increase your risk of obtaining cervical cancer. So screening tests for cervical cancer includes a Pap test, which is also known as a Pap smear. And we also do an HPV test. We do it on the same little tool there that's shown in the photo. That tool takes some cells off the cervix during a pelvic exam by our provider. They send it off to the lab, and usually within a few days, we'll get the results back if there's anything on the Pap test or if HPV has come back positive on the test also. So who should be screened for cervical cancer? Here's a yes, no, and a maybe chart. So yes, every woman 21 to 29 every 3 years. Yes, women 30 to 65 every 3 years to every 5, depending on what the last Pap test showed. So if somebody has a negative Pap test and a negative HPV test, you can go every 5 years. If you've had a negative HPV test, you can go every 5. But if you've only had a negative Pap test, you should go every 3. We also do say that, talking about risk factors and individual risk can also decrease the time of testing. So like Angelica said, please speak to your doctor, your provider, about when you should actually be screened based on your own risk assessment. We don't need to test women younger than the age of 21 for cervical cancer. And women ages 65 and older should talk to their healthcare provider about the need to keep screening. Sometimes we can, like I said, extend the time in between tests. Sometimes we can stop doing that test at all. That's sort of in the gray zone, and that really has to be a discussion with the provider. Thank you all, and I am going to hand it over to my colleague, Alejandra Hernandez, who is going to speak to everybody about colon cancer.
Thank you, Sarah. Okay, so now we're going to speak about a cancer that affects both men and women, which is known as colorectal cancer, or also known as colon cancer. Colon cancer starts in the colon or the rectum. Cancers are always named for the part of the body where they begin. So if a cancer starts in the stomach, it would be considered stomach cancer. If it starts in the breast, it's breast cancer. In this case, it would be colon. Cancer is more often found in the colon than in the rectum. As you can see, this diagram shows what a polyp can look like inside of the colon or the rectum. At this time, scientists do not know exactly what causes colorectal cancer. We do know that certain risk factors like increases a person's chance of getting this disease. There are risk factors that you can't control, such as, we've explained prior, which is getting older or your family genetics. Personal history means a condition that you have had or that you have right now. For example, inflammatory bowel disease, Crohn's disease, or polyps. Family history means that someone in your family, usually a close family member like a brother or a sister, a parent or a child, or in some cases even include grandparents. Something that they've had, like a condition that they might have been born with or that they developed throughout time, such as a Lynch syndrome or colorectal cancer. But most people who develop colon cancer do not have a family history of the disease. But other risk factors, like we talked about right now, those are the ones that you can't control. But there are some risk factors that you can control that are choices that you make like each day that you can improve, or you can, eat better, don't drink too much alcohol, stay at your weight. If you smoke, don't smoke. Just different habits that you can change throughout your life. So there are a number of ways to screen for colorectal cancer in average risk people. That means people with no family history or other risk factors for colon cancer. The easiest and quickest way is with a take-home fecal test, also known as a FIT kit, which is a stool test that is done in the privacy of your home. You could get it from your healthcare provider. You return the test after you've completed it to your healthcare provider or to a lab. There they will check the stool for any samples of occult or hidden blood. And this test is normally done once a year. The other one, which is a little one, it's one that's more popular. I'm sure most of us have heard of it, which is a colonoscopy. A colonoscopy is a thin, flexible, lighted tube that checks for polyps or cancer inside the entire rectum or colon. To prepare for this test, you have to follow a special diet and drink a special liquid that will clear out your colon so that the doctor can see clearly inside. During the test, the doctor can find or remove most polyps or even some cancers. This test is usually done every 10 years, and this test is also the test that is done if one of these FIT kits comes back positive. You can talk to your healthcare provider about when you should be screened and how often, depending on your risk factors. Okay, so now this slideshow pictures off different brands of FIT kits. One of the most popular ones would be the Cologuard, which is in the upper right hand corner. I've seen a couple of commercials on TV where they advertise it. If you're giving a FIT kit, it is important to follow the directions carefully. If the CSP, which is us, if we give you a FIT kit, we will explain the directions to you and answer any questions that you might have of how to complete the test. As stated before, if one of these tests comes back positive, the doctor will ask for further testing, which is usually the colonoscopy. I have an example of the ones that we usually provide with our program. So it's, as you can see, it's a small envelope. It's very discreet. You take it home. Inside the envelope, you will find a requisition form. This requisition form will be already pre-filled by us, so you don't need to do anything. It also comes with a sealed envelope inside. Inside this envelope, you will find 2 trash bags that you will use when completing the test. It also comes with 2 little brushes. So what you're gonna do, you're also gonna find in here is a test card. So this is a test card. So in the privacy of your home, when you're ready to complete the test, I would suggest you keep the test in the bathroom just in case, whenever you have to go use a bathroom, you see it and you remember that you have to complete the test. So what you do is you use the bathroom, then you're gonna take the first brush and you're gonna brush the stool. It doesn't even have to be like a hard brush, it's just a light brush. You're gonna take the brush and this test card comes numerated, which as you can see, it's 1 and 2. So you take the first brush, you brush the stool, and then you're gonna do number 1. And then you take this and you throw it out in the trash bags that are in. Then you're gonna take the second brush and you're gonna try to get another side of the stool and brush it as well. And then you're gonna put it on number 2. And then you dispose of the other brush. You're gonna close the test card. On the requisition form, there should be a little sticker that's gonna have your name and your date of birth, and it's gonna just ask you for the date of when you completed the test. You're gonna take that little sticker, and that's gonna seal the test. Then you'll take the sealed test and the requisition form, and it comes with a yellow envelope. Doesn't need to be, you don't have to put postage on it. It's already pre-postage. Or you're gonna put those inside and then you're just gonna drop it in any of the mailboxes that you have near your house. And that's gonna go directly to a lab. And then we would get the results. We would call you and let you know if they're positive or negative. These kits also come with a illustrated instructions, so it makes it easier. So you could see, it tells you exactly what steps to take. Okay, so men and women of all races and ethnic groups can get colorectal cancer. 93% of new cases are diagnosed in those over the age of 45, which is why it's recommended to start the screening at the age of 45. 93% of new cases are diagnosed in those over the ages of 45. That's why it's important to start at 45. If you have a positive result for a FIT kit, it doesn't mean that you have colon cancer. It just means that you need more testing to be done. Usually, if you have a positive result for a FIT kit, then you will need to have a colonoscopy. Our program, the CSP, can help you get one. You can, or help you schedule one, and will help you to understand how to prepare for a colonoscopy as well. And then for our last slide, as we've been talking throughout our presentations, what you can do to help lower your risk for developing any cancer, not only colorectal cancer. It would be to drink less alcohol, make sure you're getting enough regular exercise, staying at a healthy weight, trying to eat healthier. And like we said, if you smoke, try to quit, or if you don't smoke, try not to start smoking. Okay, thank you.
Thank you, Alejandra, and thank you, ladies, for the presentation. Here we have everyone, the contact information for the Cancer Services Program, the Adelphi New York State Breast Cancer Hotline and Support Program, and the Nassau County Department of Health, which is the Office of Health Equity. You could call any one of those numbers or contact us if you have any further questions about what we talked about today, or if you need a referral or resources. So we can go into the question and answer period now. And I want to get back to Alejandra since she just spoke about colorectal cancer. One question we have is, who is most likely to get colorectal cancer? And is it genetic or related to family history?
So the answer to that question would be anyone. You know, we are all prone, not prone, but we are all anyone can get colon cancer. So it depends on, like we said, you know, your family history has to do with it, but family history is a small percentage. So it's very important for everyone to just monitor, you know, different symptoms of their body, make sure they know what's going on, you know, if they have something that, you know, stomach pain or something that's developing that wasn't there before. It's very important for them to just stay with their health care provider and speak with them and make sure they can go with them with any concerns that they might have, because sometimes these cancers don't have any symptoms. So that's why early detection and screening is very important.
Okay, thank you. Angelica, I have a few questions for you. The first one we didn't talk about earlier, but it just came through. How important is it for us to conduct self-examinations for breasts?
So what we do know is that self-examinations don't necessarily need to be done in the systematic way they used to teach us. You know, it was almost like Cirque du Soleil, like, you know, do this, do that. We don't necessarily need to do that. The most important thing is to know your body, know when something has changed, and know it when it's normal. That way you can identify any changes that could potentially be something of concern, and then take the next step and talk to your provider about it. Don't stop at recognizing the changes. You need to tell your provider about it. And if the provider suggests any form of further screening or diagnostic test, again, don't stop, you know, there. Just continue the process. A lot of women or men, when it comes to cancer diagnosis, like they stopped at some point. So continue the process. If they tell you come back in 6 months, definitely come back. So going back to the breast examination, or just getting to know your body, it's important for that reason, but it's not sufficient to detect breast cancer. So you need to complement it with the clinical breast exam and a mammogram, and also start doing it in your 20s and continue that practice once a month in the shower. Don't, you know, make it a nice ritual. Or if you're sitting on your couch watching, you know, some movie, you can do that too. It doesn't need to be that systematic way it used to be. So just make it easy breezy, and that way you're more likely to adopt that practice monthly and get familiar with your body. That's important, but you do need to complement it with other forms of screening as well.
Thank you. We had mentioned earlier the different stages. So Sarah, can you explain the different stages of cancer? And then I'm going to come back to Angelica to talk about stage 0 breast cancer. but just in general, Sarah, the stages of cancer?
Sure, thank you so much. So all cancer is staged on a scale from 1 to 4. We'll talk about stage 0 for breast cancer in a moment in a different question, but cancers are staged on this scale dependent on the size of the tumor, if they've gone to any lymph nodes, if they've traveled or metastasized to other parts of the body. The earlier stage of cancer has a higher cure rate. When we talk about stage 4 cancer, that's not a death sentence anymore, especially for breast cancer. We have people living 20, 25 years with stage 4 breast cancer. It just means that that's more of a chronic condition, kind of like diabetes or kind of like heart disease. We're just treating the breast cancer. Then we can talk about palliative care for people that need to talk about end of life situations with stage 4. But generally, for all cancers, stage 1 to 4, the lower the cancer, the higher the cure rate.
Okay, and Angelica, stage 0 breast cancer, which in all full disclosure, right before the pandemic, I was diagnosed with stage 0. So I know what it is, but at the time I didn't know what it was when I was diagnosed. So can you explain stage 0?
Sure, and thank you for sharing that, Dr. McCummins. So stage 0 breast cancer is when there's a presence of abnormal cells, but they have not spread to any other tissue that might be nearby. So it's still very localized, and even though it sounds scary because, you know, nobody likes to hear the word cancer, immediately we think that, you know, it's a death sentence. But stage 0 for most women is very treatable, and it's good to diagnose it as early as that. So it's obviously, it's always scary to hear those words, and we're always here for support. You can always reach out to any of us. But definitely among all the stages, this is very early on, and treatment will most likely to be effective, which is a good thing.
Yeah, I feel pretty lucky that I was diagnosed with stage 0, especially it was right before the pandemic. I mean, like the month before the shutdowns. I can only imagine if I had not gone and had my regular routine examination that year, I probably wouldn't have had an exam until maybe 2021 or 2022. And that would have increased or advanced probably to a higher stage. So yeah, it is important that, you know, we get our breast exams and our mammograms yearly so that we, you know, can detect if there's any changes. So I have another question about whether or not chemotherapy is required for all cancers. Sarah?
Yes, thank you. So chemotherapy is not required for all cancers, especially the cancers that we are here talking about today. Cancer is treated in a multi-modality treatment, which can include surgery, chemotherapy, radiation, other hormonal medications. So if we're talking about breast cancer, and especially something like Dr. McCummings shared about having stage 0, the higher the stage, the more likely it would be that something would be treated with chemotherapy. But especially for breast cancers, we can look at the hormonal status of some tumors. We can look at some other risk factors like the genomics of the tumor, and we can look at that and determine if that particular patient would need chemotherapy. What we're really trying to do with every cancer right now in oncology is we're trying to make it individualized to the patient and individualized to the client and what is going on with their particular cancer and the pathological features of that cancer itself. So not everybody that has a stage 2 breast cancer is going to get chemotherapy. Not everybody with a stage 1 cervical cancer is going to get chemotherapy. We're looking at what the treatment is and what's best for the client and the patient individually.
Thank you. That's good to know. I actually didn't know that. And I did know recently a couple of my friends have been diagnosed with stage 1 and stage 2, and they're not receiving chemotherapy. And most people are really shocked about that. Like they all, most people think, you have to get chemotherapy. And of course, it's associated to people's hair falling out. So that's why people are so afraid of that word chemotherapy. But it's good to know that, with modern technology and science now, they have been able to move away from people getting, having to have chemotherapy. Thank you.
Mhm. There's actually been studies, I'm sorry.
Go
There's
ahead.
actually been studies that show that if we give chemotherapy to certain type of breast cancer patients, we could be doing more harm than good in that way. And that's why we really have gone to this individualized medicine and individualized approach. Like you were saying, some friends had chemotherapy and some friends didn't. The folks that had the chemotherapy with a stage 1 breast cancer really probably did need it.
Mhm.
So it was good that they had it. So I didn't mean to interrupt, I'm sorry.
No, that's fine. Well, I didn't mention this earlier that I would ask this question, but what about radiation? How important is radiation also, and how often do people get radiation with the different cancers, Sarah?
Sure. So radiation is used for certain types of patients. So what happens when somebody first gets diagnosed with breast cancer and they decide what type of surgery they want to continue with and to pursue? Not everybody has a choice of what surgery is best for them. Some people really do need one type of surgery over another. But what we want to do in general for breast cancer is we want to treat the entire breast. So somebody that's going to get a lumpectomy, it's pretty certain that they're also going to have radiation because the radiation then treats the rest of the breast that the surgery didn't remove. Some people that have mastectomies, which is a removal of the entire breast, may also have radiation as well because they may have a larger tumor or it may have traveled to some of the lymph nodes. But it's an external treatment. It does not make the client radioactive in any way. It's kind of like going into an X-ray table. You don't feel anything during the treatment, but it's much like a sunburn where somebody can feel the effects of it later on. A lot of the times what we say for radiation for breast cancer is that you may feel the effects about halfway through the treatment and then feel the effects, a couple of weeks later after the treatment has been completed. So it's part of that multimodality, interdisciplinary care that we're really trying to do with all of the patients.
Thank you. Okay, so let's ask this question, Alejandra. Can a full blood count detect cancers?
It depends on the cancer. For colon cancer, the best way, as we said before, was either a FIT kit that would detect blood in the stool or a colonoscopy. But the colonoscopy would be the most effective way of detecting any colorectal cancer.
Mhm. And speaking of the FIT kits, I know you showed different FIT kits on that slide. Is there any one particular FIT kit that's better than the other?
No, they're not.
And full disclosure again, I used the Cologuard last year, and it was pretty easy. It looked more intimidating. That was the one that you had up in the corner, and it looked
Yes.
more intimidating than it was. And you're right, I did keep it in the bathroom and waited until the right time. I just had to be in the right mood, right? But it did end up being a pretty easy test. You didn't have to worry about the packaging. They told you exactly what to do, and and the mailing instructions were there. You just had to slap on the sticker that they used and just take it down to, I think it was the UPS folks. So it was really easy. And for me, I've been avoiding having to have the actual colonoscopy. So that was a good alternative for me, and probably, for other people who, again, the scary part about a colonoscopy is what? They have to drink this nasty stuff that everybody always talks about, right? But the good news also is what has changed in the last 10 years or so is people are getting knocked out, if you will, for the actual test. Is that correct?
That is correct. You would get anesthesia, and that's why a lot of people would prefer, anyone that's not high risk to do the FIT test. even though it is important to have a colonoscopy sometime during your life, but it's important for you to speak to the healthcare provider, and then they can let you know when would be best. But the fit kits, they're just so convenient, so easy. You take them home, nobody has to know. And, they're pretty accurate, where they would see any blood in the stool or any other things that are abnormal. And that's when the doctor would say to come in, because it is, having to prep for the colonoscopy. It's a big issue, not eating the whole day before, having to use the bathroom, make sure your stomach is empty, and then going into a facility and having to have anesthesia. So it's a little bit more tedious and more hard work than just doing the fit kit, and that it's done once a year.
Mm-hmm. And I had a question about whether or not the fit kits actually detect the polyps. Someone says, oh, well, you have to go in and have the regular colonoscopy in order for the detection of the polyps. Is that true?
Well, sometimes the polyps can, develop a little bit of blood, and that's why, it's important for the fit kit, because then they would be, if they see the positive blood in the stool, then they would go in for the colonoscopy, and in the colonoscopy, the doctor is able to see if there's any polyps, and the polyps are removed then.
Mm-hmm. So that's why you were saying that just because you have a positive fit kit test doesn't mean you have cancer. It could just mean that the polyps are present and they probably need to be removed, correct?
Correct. Yes.
Okay, that's good information to know. Okay, and then I have one more question. And I think someone may have touched on it, but Sarah, can you tell us if someone has cancer, can you still feel fine?
Yes, that's the importance of screening. Someone that has cancer may not know that they have cancer. They may not have symptoms. For breast cancer, you may not feel a lump. You may not notice any changes in your breast. As Angelica was talking about, doing a breast self-exam, you may not feel anything, see anything during that. But that really goes back to the importance of screening. Screening is a test for patients that don't have symptoms. Screening can find cancers at their earliest stage. A screening test and a mammogram test can, see things on there that we can't feel in a breast self-exam, or even a provider may not be able to feel on an exam. But also going to the colon test, we may not know that we have blood in our stool, and that's the importance of doing the FIT test. And not everybody is going to be occultly and frankly bleeding. But what these tests do is they find microscopic blood cells in our stool that can require follow-up for polyps, which can be precancer lesions or cancers. So it really is important, even if you don't have any symptoms, even if you feel completely fine, to make sure that you're keeping up on the screening test for all the cancers.
Thank you so much. Okay, can we get that slide up again with the information, the contact information? And just want to thank everyone for joining us today. Did you ladies see any other questions on the other forms of media?
No, I think you have gone over all the questions. I believe there's one in the chat now. Let me see. Oh, no.
Oh, someone's just saying thank you in the chat. Mm-hmm.
Thank you.
Mm-hmm. Okay, and so I want to thank everyone. I want to thank you, ladies. See, collaborating is good because I couldn't do this on my own, but with collaboration, we've all had our expertise on the subject matter, and it makes for a more full and heartier discussion. So anything next? Can we say that we'd like to do this again and probably talk about some other cancers?
Yes, we can talk about some other cancers. And Dr. McCummings, you have an event coming up next week, don't you?
Yes, I have an event coming up next week. It's this month is Mental Health Month. And so next week I'm collaborating with the Department of Human Services and Mental Health and Chemical Dependency and the Hispanic Counseling Center. to present mental health in the Spanish community, Hispanic community. And the forum is going to be totally in Spanish. So that's something that we found that we need to, start doing, having these forums in different languages. So we're going to do that. And that is May 19th, which is next Thursday. I should have had the flyer available to show, but most people will send the flyers out to anyone that asks for the information. Okay, ladies, it's been very nice talking with you, and we'll see you again. Thank you.
Thank you, everyone.
Okay.
Thank you so much.
Like,